Lenticule extraction is coming as the new revolution in refractive surgery. In recent years, it is showing tremendous growth in numbers as well as more acceptance. So the different aspects of this procedure need to be discussed, will be discussed today. We have esteemed panel speakers. Dr. Krishna Prasad Kudlu is director of Prasad Netralaya Udupi and former editor proceedings of AOS and past president of Karnataka Ophthalmic Society. He will be here soon. And Dr. Kala B. Thotam, she's needs no introduction. She's one of the most prolific refractive surgeons in Kerala, and she is currently the refractive surgery chief at Chaitanya Hospital, Palarivattam. And Dr. Nimmi, she is upcoming surgeon, and she is consultant at Precise Specialty Hospital, Trivandrum. Myself, Dr. Jayaram, senior consultant, cornea and refractive surgery, Precise Hospital, Trivandrum. So we'll start with the first talk on lenticule extraction. Is it better than conventional refractive surgery? So I will be talking on that. So refractive surgery. 2 surgery trend from 2010 to 2015. You can see that from 2018, the lenticule extraction procedures is showing a tremendous growth in numbers. And also from 2011, lenticular extraction started, and 2020, new machine manufacturers are coming into picture. Schwind in 2020, Zeiss 2022, 23, Zimmer, and then Johnson & Johnson, which shows that the increasing numbers and more manufacturers coming into the market shows that it is a able and procedure which gives good results. And you can see here in the numbers that and the numbers of lenticular extraction is around 1.5 to 2 million per year. And Fekikaya was also showing a explosive growth recently. So regarding the advantage, biomechanical and corneal integrity is the main one of the main advantages of refractive lenticular extraction, which shows that the stronger cornea by retaining the superficial lamellae and avoiding the side cuts gives a definite advantage. These are the studies which show this advantage of lenticular extraction. And in these long-term studies of SMILE have shown that long-term the results are good, as well as there is less chances of ectasia. And now the latest studies are coming in with platform diversification with better quality of vision with lower energy and cyclotorsion control, which gives better result in astigmatism. So the clinical outcome trends show that the increase in biomechanical stability, which preserves angiostroma, and stronger biomechanics in LASIK and PRK. The dry eye advantage due to faster nerve recovery due to nerve flap creation, and better visual recovery due to less higher order aberrations induced. And these are the results which show that the studies which show that the absence of dry eye disease, absence of flap related complications, and vision and other parameters are comparable. So these are the studies which show that the biomechanical changes after SMILE and LASIK, which shows lesser biomechanical weakening and lesser change in cornea's biomechanical properties after lenticular extraction. And dry eye disease also, several studies have shown that the advantage of lenticular extraction as far as dry eye disease is concerned compared to other refractive procedures. Also, higher order aberrations after lenticular extraction is lesser than other refractive procedures. But limitations are the SMILE specific issues as suction loss, difficult dispersion, cap tears, retained fragmental lenticule, and enhancement options are more complex. And wavefront guided topography guided treatments are currently more established with excimer laser based techniques. And careful surgical technique and a learning curve is important for minimizing intraoperative events. The future directions are improved femtosecond platforms for shorter treatment times and better early vision, customized lenticule profiles and normograms for high myopia, astigmatism, and potentially hyperopia. The reuse of extracted lenticules for therapeutic indications, basically post-LASIK ectasia, keratoconus, and hyperopia, and integration with cross-linking protocols for at-risk cornea, SMILE, extra, and related approaches. So coming to the question, is lenticular extraction better than conventional refractive surgery? As far as visual acuity, safety, and predictability is broadly comparable to femtosecond LASIK in most RCTs and meta-analysis. Biomechanics, dry and flat related issues, lenticular extraction shows meaningful advantage in many, but not all studies. Technology and surgeon experience strongly influence the outcome of both lenticular extraction and LASIK, but its learning curve is more in lenticular extraction. And the bottom line is lenticular extraction is not universally better, but offers distinct advantages for selected patients and indications. Thank you for your patience. on who is fit, indication, patient selection by Dr. Nimmiraj.
Good morning, everyone. I'll be talking on who is a fit patient for a lenticule extraction procedure. I have no financial interest in whatever machine being told in this presentation. So the keratorefractive lenticule extraction surgeries are the upcoming or most newest technology of refractive surgery in which a small incision is made and a lenticule is removed from the cornea to correct the refractive error. It is currently approved for myopia and myopic astigmatism, and many studies show that it has a safety, efficacy, predictability and outcomes which is comparable to LASIK, which is a refractive surgery which has been there for the past 30 to 40 years. And even in spite of having a steep learning curve, this surgery has gained global popularity because of the long-term stability of cornea that the surgery provides. There are various platforms. The only FDA approved ones are Smile and Smile Pro. Smile was approved in 2016, but surgeries were being done from early 2008 itself. And after many studies, it got approved finally in 2016. But the problem was that it didn't have tracking systems or cyclotorsion correction parameters or softwares in it. The Zeiss came with a updated version, Smile Pro, in 2022. It came and it got FDA approved in 2024 with softwares for cyclotorsion and also a faster. The laser pulse repetition is at faster rate so that the lenticule is cut within a dramatic time of less than 10 seconds. Smile is approved for treatment of power -1 to -10 diopters. Lesser myopia like less than -1, it's not approved. And also it is FDA approved for -3 diopter cylinder. Recently in an updation in 2018, initial approval in 2016 was only for spherical correction, or the astigmatism correction was allowed only up to 0.5 diopter. But in an pre-market approval, FDA has approved for cylindrical correction up to 3 diopters in 2018. Now newer platforms have come. Clear, SmartSight, Silk are examples. These are approved not by FDA, but the European Conformity has approved these and have regulatory approval to use in Asia and in Asia and Europe. They are approved to be used. These newer machines have centration and cyclotorsion correction features, and the initial results show that they are promising machines for future with comparable results to that of Smile. So for any refractive procedure, the age of the patient should be more than 18 years at least. FDA approved for lenticule extraction procedures is 22 years. Clearly suggests a stable refractive error to be documented. That is, there should not be a major change in spherical or cylindrical power during the past year. The equivalent change should be less than 0.5 diopters. The patient you select should be off contact lens. For soft contact lens, it's 2 weeks, and rigid contact lens, it's 4 weeks. Free of any ocular pathology and adequately counseled, and patient having realistic expectation is of utmost importance. Contraindications, as in any other procedure: unstable refraction, abnormalities of the cornea, if the corneal thickness is insufficient, if there is any other problem like visually significant cataract, uncontrolled glaucoma, any other external disease which needs to be controlled before the procedure like blepharitis, dry eye, atopy, allergy, which has to be taken care of. Autoimmune diseases, if present, is a contraindication. Pregnancy, lactation is a contraindication. And if your patient has unrealistic expectations, that patient is not suitable for a lenticule extraction procedure. Especially patients with excessive anxiety, depression are prone to have more suction loss also during the procedure and are a relative contraindication for the procedure. In preoperative assessment, you will document the use uncorrected visual acuity, best corrected visual acuity, IOP. In refraction, you have to look for both the refraction current and past refraction. If any document available, that has to be cross-checked for ascertaining the stability. astigmatism has to be taken care of, especially as we are going for a lenticule procedure. Obtain manifest and cycloplegic refraction, and if there is any disparity of more than one diopter, that also requires a re-evaluation. In clinical examination, before going ahead with the lenticule procedure, prominent frontal ridge, external appearance of the patient also has an importance, especially if the surgeon is a new surgeon. Prominent frontal ridge, prominent nose, deep set eyes, that might lead, have suction loss, increased chance of suction loss, that has to be told to the patient prior itself. Also assess for any squint, any lid closure abnormalities like lag of thalamus. Look for dry eye blepharitis. In cornea, look for any scars, vessels, signs of inflammation, any subclinical dystrophy features. If you are seeing, those patients are not suitable for lenticule extraction. While examining in the slit lamp itself, if you can make out a large angle kappa with the slit lamp light itself, that also is a sign that you have to counsel the patient prior with regard to the expectations in the post-op. Look for any cataract, fundus detailed evaluation as in any other refractive surgery is required. Detailed investigations including keratometry, cornea topography, pachymetry, pupillometry can be done. Dry eye evaluation is also advisable. Any patient with the refractive error as -1 to 10 diopter, -0.75 to -3 diopter cylinder is FDA approved for undergoing SMILE. The normal values for RSBT, residual stromal bed thickness, is 250 microns. Percentage tissue alteration, that is the lenticule thickness plus cap cut divided by CCT, should be less than. You should not alter more than 40% of the total thickness of cornea. Lesser CCT, like 475, is a the patient below that is not suitable for the procedure. Also, a mesopic pupil size more than 7 mm, the side effects or the symptoms post-surgery like glare and all will be more, so that also has to be taken care of. Any abnormal topography pattern, any foam frust, even minor changes in the topographic pattern, the patient is not suitable for refractive surgery or lenticule extraction. Who will benefit? Patients with pre-existing dry eye, definitely, because as the incision made is larger in LASIK and more of basal nerve plexus is cut, patients with pre-existing dry eye disease is going to definitely benefit from a SMILE procedure. Nowadays, even with 2 mm, 2 to 2.5 mm small incision itself, lenticule can be extracted. So in patients with dry eye disease, SMILE is an excellent choice. There are many studies which show that immediate post-op period, definitely SMILE has an advantage, but over long term, both the procedures tends to have similar incidence of dry eye. But for that initial comfort and all, SMILE is a better option. Engaged patients, people engaged in contact sports are likely to have flap-related complications with LASIK. So the absence of flap and also maintaining corneal strength as lesser fibers are cut is an advantage for SMILE. Patients with thin corneas, even though the most preferred procedure is PRK, prefer keratorefractive lenticular extraction procedures over LASIK. So least preferred will be LASIK in those patients, as there can be chances of ectasia post-operatively. In higher refractive error patients, few studies, even though it is not FDA approved for more than 10 diopter power, a few studies have shown that if for a more than -10 diopter power, if the thickness permits, Kellex surgeries will be better than LASIK. In patients with larger mesopic pupil size also, when compared to LASIK, the postoperative complaints like ghost images, glare, etc. will be less with SMILE. Patients who will not benefit will be patients with hyperopia, because there are no platforms that is giving us results with hyperopia. But LASIK and PRK, we have options for hyperopia correction also. For corneal diseases, epithelial lesions and all, PRK is a preferred procedure. Higher astigmatism, FDA approved LASIK parameters is -6 diopter. And also if there is irregular astigmatism, higher order aberrations, wavefront guided, topo guided treatments are available only currently in LASIK and PRK platforms. In low myopia, complicated orbital anatomy, etc., if the surgeon is less experienced, there are chances of retained lenticule as the lenticule thickness will be less, and also chances of suction loss is more. That cases we have to be cautious. In patients with significant preoperative anxiety also we have to be cautious. And regarding visual recovery in Kellex, the variability of visual recovery is a problem. So hitting the sweet spot with respect to energy parameters in your particular machine can be the key factor in achieving best visual acuity postoperatively. Then another limitation is the lack of enhancement options. You cannot do a repeat smile in a patient whom you have done a smile procedure already. So you have to go on to do a PRK or a lesser flap thickness LASIK in those cases. And as I said, the customized options or wavefront topo-guided options are less established with SMILE. All these procedures are comparable in efficacy, safety, and predictability. And what you will select depends on many criteria. Patient selection is of utmost importance. Meticulous evaluation, detailed evaluation with all the investigative modalities available is important. A thorough understanding of patient's need and tailor down the options. Clinical scenarios have to be assessed and decide a patient. You must choose, but always choose wisely. Thank you.
Thank you, Dr. Nimmi, for that extensive talk on diagnostic evaluation. Now inviting Professor Prasad Kudlu for the art of precision, surgical technique and technology. Healing right, postoperative care and management.
Well, good morning. Thank you, Dr. Jairam, for giving me the opportunity today. Dr. Jairam and Nimmi has already talked about the pre-op evaluation and the overview of lenticule extraction. So we have been doing lenticule extraction for the last 1 year now. I'm doing silk for the last 1 year. It is there in the practice. Dr. Kudlu and all are doing for the more than 10 years now, I feel. So I'll be talking about the healing pattern compared to the already established PRK and LASIK procedures. This is a first day picture of a patient post silk. The section, the cornea looks and the interface looks very clear. So before going into the healing pattern, let me begin with the basic post-op uh, care. After silk procedure, we give a standard regimen of antibiotics for 1 week, steroids we taper over 4 weeks, and tear substitutes we'll be giving for 4 to 6 weeks, and always give eye shield for 1 week while sleeping and sunglasses for 1 month. And patients are instructed not to rub the eyes, avoid tap water, avoid eye makeup for at least 1 month. The post-op outcome on day 0, the patient may feel fogginess, slight spreading. Patient, even though they see 6 by 6 or 6 by 9, but the vision won't be crystal clear on day 1, but still the functional vision improves rapidly over maybe in 1 week time. The vision improves rapidly. The basic physiology of in healing post-op is, as they have already mentioned about the nerve preservation. Unlike in LASIK, we are not making it 300-degree flap. The corneal nerves are not disturbed much. The anterior stromal plexus are preserved, so there is less induced dry eye, and the structural integrity of the cornea is also maintained because the anterior cornea as well as the movements are not disturbed much. So post-op outcome, the visual recovery mainly depends upon the femtosecond laser energy, the spot sizing, the scanning pattern, and the surgical techniques. The day 1 result can be affected by the inherent elasticity of the patient's eye. The heart of lenticule extraction is the energy optimization. The concept of energy optimization is basically to balance the effect of femtosecond laser energy, the tracking distance, the spot separation. When the energy is high, it can lead to OBL formation that can affect the vision on day 1. It can lead to interface haze also. And too low energy can cause more adhesions that we have to give extra energy for the separation that can cause Bowman's membrane damage and lead to, again, it can affect the vision. So what we are looking for a sweet spot of energy levels where it is not too high, neither low, so that we can have a clean, smooth separation and extraction of the lenticule. And lenticular schisis is a new technique wherein we don't actually separate the lenticule. It's like a capsulorhexis. We remove the lenticule just after, with a forceps, just peel off like a capsulorhexis so that the manipulation can be reduced. And the trauma to the epithelial cells and the stromal tissues are much less, so that the cytokine release and is also reduced. Similarly, the keratocyte apoptosis proliferation as well as inflammation is much less compared to the LASIK and the PRK procedures, and less damage to the stromal nerves. Thereby it preserves the subbasal plexus and leading to faster visual recovery. Immunohistology studies have shown that CD11B is considered as a marker for inflammatory infiltration, showed that there is distinct difference between post-LASIK and post-CLEX eyes. It is always remained low after CLEX procedure, even with high power correction. Unlike in eczema laser, when we give ablation for higher amount of correction, there is always inflammation is more compared to the lower power correction. There is more release of cytokines and chemokines. And the nerve plexus regeneration is faster because we are not damaging the nerves at like in LASIK. Only at the upper portion, there is a 2 to 4 millimeter incision. So the nerve regeneration is faster and less dryness. That will improve the functional vision from day one. Studies have shown that the subaxial fibers start to regenerate by end of 1 week, and there is significant improvement in 4 weeks' time. Similarly, the corneal sensation also begins to regain within 4 weeks and peaks at 6 months. It's a confocal microscopy picture showing the nerve regeneration in PRK, and it is moderately better, but the LASIK, the nerve regeneration is much slower compared to the CLEX procedures. To conclude, energy optimization, we have to find the best energy and according to the patient eye, according to the power, we have to titrate. We have to come to a nomogram, like we have to find our energy parameters. The companies usually give a standard parameters. We'll start from one end, but we have to find out by doing the titrating the energy levels, which is suitable for according to the power. We have to find out the energy levels, which causes minimum tissue trauma to the eye. And definitely the procedure itself preserves the corneal nerves. That will helps in healing and less inflammation. It gives a rapid visual recovery. Thank you so much.
The questions discussion will do after all the topics are over. Now to Dr. Krishna Prasad for his 2 talks on art of precision, surgical technique and technology, and what is in pipeline, future of lenticule-based surgeries.
Next. No, first I got that teaching video. No, there are 2 talks.
Yeah, 2 talks.
No,
First-
other talk, first talk.
Yes, and
Surgical
technique.
Not this. Alt of last. Can you just change? Yeah. Can you play the video? So learning curve in smile is, I think, very, very important. Always being a doctor, I myself explain to the patient how exactly he has to behave on the table. So optimum application of the anesthetic drop is also very, very important. So always try, just put a drop or 2 maximum so that epithelium will not be loosened up. Being a doctor, always I myself check all the parameters in the machine, very, very important, including the energy setting which has been mentioned by the Dr. Kala. Once everything done, then machine will start calibrating for that particular patient. Proper draping is very, very important. Make sure that the surgeon will have very comfortable space to operate. There should not be any eyelashes coming on the way. Adequate wash of the ocular surface and the cornices is very important. Make sure that conjunctiva will be dry and cornea will be semi-moist. So head positioning is so important. Sometimes patient with a long nose, you may have difficulties to dog. So always you should tilt towards the opposite side. Connecting and selecting the appropriate size cone, important. In Indian scenarios, we take a small size cone. Take for right eye, you take in the right hand and hold the cone or contact lens in the right hand. Go to the slot, you take it up, then you'll hear a click sound. Once it is click sound, already the machine has already started calibrating for that particular cone. So white to white less than 12 mm, always 80 to 90% application is sufficient. More than 12 mm, 100% application you have to do. So we started with the flex. I just wanted to tell all my friends how this smile has been evaluated. So we started with flex. So the treatment will be done by the machine, similar kind how it does with the smile. This is what I learned 14 years before. So it started with the flex. So it has done treatment in both anterior and posterior plane. You could able to see. Once the dissection of anterior plane, then you have to lift the flap only. See, now I had lifted the flap here. Now I go with the smaller end of the dissector. I try to dissect the bed to look for the lenticule. So once you look for the lenticule, then it's quite easy. Make sure that you are dissecting, then go with the micro forceps, try to do something called reverse rexis. This is how we started like this with the flex, then reposit the cap back, nice ironing, so that the procedure is quite similar to the LASIK. Then we thought how we can really convert this. I just wanted to show you the evaluation of smile. From flex, then we started thinking about, okay, let us do something called pseudo smile. This is what me and Dr. Rupal started. So treatment is similar, like you started with a posterior cut, then with the cap cut. So here the incision has been done by the machine, similar kind, how it is with the flex. But here what I am doing, I am not opening the cap at all. So to train myself as a smile surgeon, I started with the flex. So first I identify the anterior layer, then followed by the posterior layer. So probably this is what when Dr. Professor Tithial started, he was there, I was there for that particular training. So go with the longer end of the dissector, try to dissect in the anterior or the superior plane. See, you could able to see while doing only some of the flap might have been already cut. The incision might have gone from 4 mm to 7 mm. But I wanted to make sure that how exactly we have to do the smile procedure. So dissect the anterior plane properly. Now go to the posterior plane, try to dissect. So the one very important point I want to tell, when you dissect in the posterior plane, you dissect both the side equally. Otherwise, the entire lenticule may come and fold to the one side. So you have to dissect in such a way that you dissect both right side and left side. That means nasally and temporally equally, so that the lenticule will not be folded. Once the dissection over, then you go with the micro forceps. You try to take out the lenticule and you can put it over the cornea to look for the integrity of the lenticule, whether it is proper or not, whether it is round or not. Once it is done, then I think how you do with the smile, the ironing of the cap has been done. Then we started the smile. So smile, as you all know, that it starts with the first the lenticule cut, then with the cap cut, then with the incision. Initially we should start with the 4 mm, then you can reduce up to 1 mm also. Now identifying the right plane is very important. First you identify the anterior plane, then you followed by the posterior plane, then you turn the dissector into the longer end, then try to go in the anterior plane, try to dissect something called a windshield wiper movement. So this movement I think really help. I think any of this CLES procedure you have to do this kind of movements only. Now you go to the posterior plane. As I said that when you are dissecting the posterior plane, don't dissect one side. Both the side, both nasally and temporal, it has to be dissected equally well so that lenticule will not be folded. You can even use a simple McPherson forceps to look for the integrity of the lenticule. I want to just share with some of the complication also can happen when we started with Visumax 500. The incident of suction loss was quite high. See here you could able to see already there are black spots are there. The very uncooperative patient, you could able to see there is a suction loss. So not to become panic, suction loss during the lenticule cut, you can convert into the femtolasic on the same step only. If the suction loss during the other step like side cut, cap cut or incision, then need not have to, you can reduce the optical diameter by 0.5, then go back to the incision, recentration after the suction, then clear the bubbles from the center of the cornea, wipe the undersurface of the contact lens, then immediately you redock it. It will do the treatment in the same plane. These are some tricky situation. One of the retained lenticule I wanted to show you. Treatment has done perfectly by the machine except for few OBLs. First, the identifying the anterior layer is done perfectly well, then followed by the posterior well. See, now you see, this is one of my favorite student now. He is one of the leading refractive surgeon in Delhi. I don't want to name him. He started with the anterior plane perfectly. Then he went to the posterior plane without took his eyes off. Then I told him, you take out the lenticule. He took out the lenticule. Then he has put it over the cornea. There was only half lenticule was there. Then he was become panic, not to become panic at all, because Zeiss always give a fantastic microscope, or someone can even use the triamcinolone. Here I did not use the triamcinolone. I fine focused it. I know where it is exactly the remaining lenticule is adhering. Go with the longer end. Try to dissect very smoothly. You should not become panic. Try to dissect it out completely out. Then go with the microforceps. Wherever it is adhering, try to go towards the 6 o'clock. That is away from the incision. Then you can take it out. Then put it over the cornea. Then I got the remaining lenticule which I kept in the conjunctival sac. I joined it. Now it has become perfect. So always you can come out with a good result. How to avoid thin lenticule have higher risk of tear during the dissection? Dissection has to be gentle, no forceful dissection. This is the key one factor. This is a one more case I am showing you, lenticule and flap. Say treatment is done perfectly by the machine. Identification of the both anterior plane and the posterior flap also done by the doctor really well. Now the surgeon really gone with the longer end of the dissector. He started dissecting. So I could able to see when he is dissecting, it is very smooth. Now he is trying to look for the posterior plane. He is inability to see where exactly is the plane. So what went wrong? Multiple entries in the interface during the dissection, inability to identify the correct plane during the dissection. So how to manage it? So go with the shorter end of the dissector, try to scratch the cap. So when you start scratching the cap, suddenly this lenticule which is adhering to the cap, which is going to open. Once it is open, then you can either go with your microforceps, or you can introduce your longer end of the dissector within that gap, so that you could be able to dissect it. How you dissecting the posterior plane? As simple as that, not to become panic, keep your head cool. Then wherever it is adhering, you can go with the microforceps, try to dissect it out. Then I think like how you doing the reverse rexis in cataract surgery, you can take it out and you can put it over the cornea. See, points to remember, always identify the anterior and posterior plane properly. Multiple entries has to be avoided. Anterior plane has to be dissected first, followed by the posterior plane. So this is one more case. One is biggest irritating for any of the surgeon is black spots during the surgery. See, you could able to see a lot of black spots are there. What are these black spots? These are the areas of untreated corneas. So normally everybody will have a difficult dissection. So how to manage? Always in this case also you should identify the plane correctly. Most importantly, be calm, be confident. So go to the plane first, anterior plane. You will have all tough spots, or you may find a little bit stiffness while dissecting. Try to dissect it, then go with the microforceps. You may have a little bit more difficulties, then try to dissect it while peeling also. Hold it wherever it is holding, slow peeling, like you should go to the 6 o'clock, go and try to take out the lenticule. Successful removal of the lenticule is always possible. So, how to avoid? Keep the conjunctiva and fornices dry while cornea has to be moist during the treatment. Avoid excess of applanation of the cone while docking. In the small cone, as I said that only 80 to 90% sufficient. If the black spots are extensive, then I think you can go ahead with the PRK. Thank you. I thank Dr. Jairaman and the entire team of this course, and I'll be continuing with my other talk. Can I go to other talk? Yeah. So Jaraman wanted me to talk about what's in pipeline, future of lenticle-based surgeries. I think few of the points I think Kala already been spoke, but still I want to brush upon. See, we started PRK in way back 1995. Then later on in the 2001, the femtolasic has been introduced. The flex, what I showed, which has been started in 2007, but Smile started in 2011. So I started Smile almost around 2012 or 2013. So USFDA for Smile for spherical correction 2016, 2018 for compound myopic astigmatism. So what exactly the definition of CLEX? CLEX is a keratorefractive lenticular extraction which was proposed in a joint editorial statement in the Journal of Refractive Surgery to encompass all the preparatory terms for corneal lenticule extraction surgeries for refractive error correction. This is flex. So we have got flex also, you got relax, you got smile, you got silk, you got clear, you got smart light also. So smile, silk, clear, smart light comes in the flex classification. So these are the smile is small incision lenticular extraction. Silk means smooth incision lenticular keratomeliasis. Clear means corneal lenticule extraction for advanced refractive correction. Smart sight is smart small incision guided human cornea treatment. So we started with Visumax 500, the frequency of 500 gigahertz, intrastromal refractive lenticular extraction. Basically a flapless procedure, no ablation, no flap. Then it's a single step, one step procedure with a single system. It has got the Smile machine Visumax 800 has got a computer in it, laser arm, vacuum system, microscope and foot switch too. This is how it works. It has got a low pulse energy with a high pulse frequency. So I will not talk about spot sizing between 2 to 4.5 microns. Track spacing distance between the two laser spot is adjacent track is 2 to 4.5 micron. So scan direction is conventionally spiral in for posterior plane and spiral out for anterior plane. So there are three modes are available. I am not going to talk about. One is standard mode, one is fast mode and the expert mode. These are the surgical step already showed in my previous step. So I am not going to talk in detail about the surgical step of smile. So basically, as I said that this is the cross section, how exactly smile looks in the slit lamp. So this is the, again, I just want to brush you up. This is the basic, the first video I have done, it is almost around 12 years before. Started with the, how, with the lenticule cut, followed by the cap cut and the incision. Identifying the proper layer is very, very important. First anterior layer, then posterior layer. Dissect the anterior layer like a something like a windshield wiper movement. Then go to the posterior layer. Then try to dissect both the side equally. Then you can take out the lenticule even with the simple forceps. Put it on the cornea. Look for the integrity of the lenticule. So other platform I want to touch upon here is first is the Zimmer. So Zimmer newly developed something called with the help of their femtosecond machine, Femto LDV Z8, which can now they are changed into a Femto Z8 Neo. The advantage that is the treatment what it is done is clear. There is a corneal lenticule extraction for advanced refractive correction. So what they claim, it has got a low energy, smooth dissection of lenticule and cyclotorsion compensation also there. But again, it is not been FDA approved. So coming to the Swind Etos Smart Sight. So the advantage, it has got an intelligent eye tracking system with a cyclotorsion compensation with a more tissue saving, which is compact and flexible and smooth and tissue saving. Again, the machine still it is not FDA approved. So what exactly we do in Swind Etos, the microcut technology, it exhibits something called a homogeneous surface. As a result, lenticular extraction will become simple with a precise treatment. So now comes what Dr. Kala was talking about, the Johnson & Johnson Elita. That is, it do the silk, that is the smooth incision lenticular keratomeliasis. So it has got a, because of the ultra precision pulse, better quality treatment and ultra fast delivery, exception is smooth surface, and also it is with the superior optical performance. The most important, probably they claim that in industry there is a first biconvex lenticule it has got. So because of that, the less corneal folds in the Bowman layer and leading to improved nerve degeneration, less cutting of the corneal nerves and fast regeneration. So now I think as I started looking at the Visumax 800, there's something called Smile Pro with 2000 Hertz, faster performance, faster cut speed with the cyclotorsion compensation, central align, easy patient access, but the treatment time in Visumax 500 is around 30 seconds. Here treatment time is less than 10 seconds, so there is absolutely no question of suction loss. But the most important, now they incorporated hyperopic treatment in this particular. So what is there in pipeline? So as our initial speaker was telling, about can we do a secondary smile? They have been working on, especially you can do the previous secondary smile on the previous smile cap. You can go below the previous smile pocket. We need to further trial is still going on. But we are thinking about subcap lenticular extraction, that is something called modified repeat smile, which can be performed at the same depth as the first procedure without anterior cut, with a previous interface which acts as a superior border. I know that it's technically challenging. So this is a small comparison with the other platforms I just wanted to show you. With the Smile Pro, Silk, the Silk with clear and smart light. If you see here, the treatment range for Smile is -1 to -10, but they are given me the license of even up to 14 only for trial purpose. Cylinder which has been up to 3, that is what the FDA approved. But Silk you can treat up to -12, cylinder up to -6, clear you can do up to -10 spherical with -5 cylinder, and the smart sight -5 to -12 with the 6 cylinder. But in Smile also you can go up to -4.95. So cyclotorsion compensation was not there in Visumax 500. Now it has, this is a comparison with the Visumax 500 I am giving you with the Silk, Clear and Smart Sight. So cyclotorsion compensation was not there in the Visumax 500. Now it is with the Visumax 800. Then all other machine it has got a cyclotorsion compensation. Pulse energy again with the Visumax 500 was little bit higher when it's compared with the Clear. So what I think yet the results yet to come for, I think probably 4 to 5 years of comparison with the other platform. What they say that if you got any machine with a low pulse energy, that reduce the collateral stromal disruption. So we need to look into the coming time. Then pulse frequency, if you see here, I think so Smile has got a very less pulse frequency, but always what they say that higher the pulse frequency, smoother the cuts. But I was just discussing with one of my very close friends who were doing Clear. The next day wow factor to get almost takes around 15 days to 20 days. So I don't know. There is really controversy while putting this slide. But this I picked from one of the journal. So coming to the spot spacing, in Clear it has got a overlapping. That might be the reason, probably the long duration for visual recovery. But in all other technique, but as Kala said that in spot spacing in Silk, which is less than 1 micron, which is the unique feature of Silk. So laser pulse duration, of course, Silk has got a much lesser laser pulse duration compared to any other platform it's seen. So higher the pulse duration, what they say that the more thermal damage to the corneal tissue. Corneal cap thickness, I think in Smile, I have done Smile cap up to even 90 micron, but Silk you have to do, I think 110 micron is the cap, but Smile you can vary the cap thickness. In Clear it is between 120 to 140 and Smart Light is 120 to 150. But what they say, thicker the cap, better biomechanical stability, I don't know. But when you are treating a very high refractive power, you have to take a very thin cap, then only the treatment will be perfect. You can save more tissue. That's what I understood. So residual stromal bed for Smile 250, but here nobody goes. In my case, with a very high refractive power, I still keep it around 270, 280. Sometimes I go with the Smile extra, with the I combine with the Smile cross-linking. So lenticule pattern in Smile, as I said that, for anterior it is circular pattern out to in. For posterior, circular in to out. In Silk, it has got a radial pattern, Clear circular pattern out to in, and Smart Right spiral pattern which is center forward. So suction loss again with the Visumax 500 suction loss was high. In Silk it is 0.32, but if you see with the Visumax 800, the suction loss rate is almost next to 0. So OBL was quite higher in the Visumax 500. Then as Kala said that once you start doing your energy setting, this incidence of OBL will come down. Higher order aberration with all these treatments are almost same, around plus or minus 0.26, which is similar in all of the cases. This is the cumulative comparison between Smile, Silk, Clear and Smart Light. The visual recovery after 1 week, 3 months, 6 months. In the end of 6 months, I think all treatment, I feel the results are fantastic. The only thing is, Smile, when you're docking, the amount of intraocular pressure it exerts on the cornea is around 20 to 30 millimeters of mercury in compared to Silk. And I think it was also the around 30 to 40 millimeters of mercury. Sometimes I think next day post-op patient with a tomato eye and the dread eye might be much lesser in Smile compared to the Silk. Of course, compared to the PRK, LASIK and CLEX, definitely CLEX has got a faster recovery, shorter duration, less dry eye. But PRK again good for thinner corneas. But CLEX no flap related complication, better quality of vision, better biomechanical stability according to some of the studies. Of course, these are the advantage and disadvantage with all these procedures. Again, CLEX still got a advantage on all these procedures. So I thank Jairaman for this opportunity. So I came all the way from Udupi, reached today early morning and part of this wonderful course. Thank you, Anand.